Hello, everyone. I'm Shelley with 50 Up Health and Beauty, and welcome to another segment of my expert series. Now, today we are examining a topic that causes more anxiety than a first aid, and that's Medicare and Medicare Part D. Now, many of us that are 65 or older are trying to figure out which plan is right. And honestly, we're all a little stressed about the hidden costs, especially when it comes to prescription drugs through Medicare Part D. This is a huge concern for anyone managing a chronic condition. So today, I have a very special guest, Margaret Johnston. Now, Margaret is a highly qualified family nurse practitioner with extensive experience in functional health care for diverse populations. She holds a Bachelor's of Arts in Sociology from Occidental College and a Master's of Arts in Sociology from California State University, Los Angeles. Margaret has also earned an associate degree in nursing and a Master of Science in Nursing from Azusa Pacific University. And she is a clinical nurse specialist in medical surgical nursing. In addition to her impressive educational background, she is certified as a family nurse practitioner and has been recognized with honors such as the Sigma Theta Tau National Nursing Honor Society and the Sigma Kappa Delta National Sociological Honor Society. Margaret is also an ACLS and BCLS instructor and has significant research experience, including FDA clinical trials and presentations at notable conferences. Currently, she practices at the Hubert Humphrey Comprehensive Health Center, focusing on implementing functional medicine programs. Margaret's commitment to continuous improvement in healthcare and her wealth of knowledge make her an invaluable resource for our discussion today. So let's welcome Margaret Johnston. Margaret, I thank you so much for being with me today, and I'm sure that the people on the channel are really going to appreciate your expertise. Now, one of the things that I think would be really helpful if we could start out with about talking about Medicare is for you to go over the 4 parts of Medicare and kind of explain to people what they are.
Well, first of all, Shelley, I'm really glad to be here because I'm talking to people about a very important subject. Because you never know when you're going to be disabled, and we have the inevitable process, we all get older.
Right.
So first of all, let's start out with the first types or parts of Medicare. Number 1, you have your benefits under Plan A. Now, Part A covers your hospital, your hospice, and your home health services. Now, most of people get this automatically because we've worked for more than 10 years and have contributed to Social Security. And I do want to make an important caveat is I encourage people to work beyond 10 years. The reason is that you may be tired, but it's important to pay into the Social Security system because if you've worked for under 10 years and you start to collect your Social Security, you're going to be hit with a surcharge, which you'll have to pay on a monthly basis depending on your income for not having made enough of a contribution in Social Security. So among my patients I hear, so I'm tired, I just want to retire, but I try to point out to them that women don't do very well on Social Security anyway, and getting more money into your account in Social Security can actually take care of the surcharge or you can avoid it completely.
Well, that's really good. I didn't even know that myself, so that's an important point.
It is, especially when you're planning when you're going to retire.
Right. I think, for a lot of us that were in corporate America, we worked beyond 10 years. So
yes.
It never really came
Yes.
up. But for, if you're looking at a breadth of patient population, you're seeing a lot more diverse patients than, make people in the working category.
Well, some of us found what we love. And I love what I do.
Yeah.
Now, as Shelley probably will explain, I'm a nurse practitioner working in the public domain. And it's the best work I ever have done or ever hope to do. Now let's go on to Part B.
Yeah, there you
Now,
go.
Part B actually covers your outpatient expenses. So it will cover your doctor's visits, your x-rays and your diagnostics, as well as your labs that would be ordered periodically. Now, there is a caveat. There is a cost to this. Now, most people actually have it deducted directly from their railroad pension or possibly from their Social Security check. Now, again, this is pegged to your income, not the income that you retired on, but rather your income that you're going to receive under Social Security.
Mm.
Yes, so that is something to think about. But again, you're going to be penalized if you enroll for Social Security late. So do remember that once you leave your employment and your employer provided insurance, you've got 8 months to apply for A and B and start to pay for it.
And that's if you're 65.
Well, that's if you're retiring.
Okay.
And some people retire before because they have disability. They might be on Social Security income. They might be on Social Security disability. So there are some different categories that we have to consider.
Okay.
But again, do get everything paid for before the 8 months expires. Otherwise, you're going to end up with a yearly surtax that goes up with inflation. And that just keeps on going.
Okay. So out of this, the summary would be, number one, at least work 10 years.
Absolutely.
Right, work 10 years. The other thing is once you leave a corporate environment or you retire,
Right.
you have, what, 6 months? Is that what you said?
You've got 8 months.
8 months. You've
That's
got
it.
8 months before you have to make sure that your coverage is, or you've
It's
initiated.
implemented without a surtax.
Okay, there you go.
And the way I like to view these extra costs, they're surtaxes for not having done something at the correct time or in the correct order.
Great. Okay.
And you don't want to be saddled with it for the rest of your life, because that's exactly what happens.
Oh, okay. Good to know. Good to know.
Exactly. Matter of fact, I really advocate that people should keep on working because of the uncertainty of Medicare, Medicaid, and what's going to happen in the future.
Right. Right.
Now, moving on to Part C. This is probably the most interesting part, because this is where you have to make a really hard decision to choose between traditional Medicare and what they call Medicare Advantage. So just a little history. Under the Bush administration, Medicare Advantage was introduced as a separate type of Medicare to help save monies, because it was putting the Medicare recipient, who traditionally could go to the doctors that he wanted to or not, or go to the hospitals of his choice, into a managed care organization that watched the P's and Q's and limited whom the person could see and what hospital they could go to. So with that said, I think you're going to know where I'm going next.
Right.
Let's compare traditional and Medicare Advantage. So traditional Medicare is widely accepted by clinics, hospitals, and doctors. Why? Because it will pay for what's medically necessary. Now let's compare that to a Medicare Advantage plan, where you're going to get a 25% reduction just going in the door of the covered fees and privileges and benefits. Another thing is that you're not going to have choice. And with traditional Medicare, you can go to the cardiologist you choose to. You can go to the hospital that you choose to. And there are no delays in care. Medicare Advantage has to have everything approved. So if you want to go to the cardiologist, your primary is going to have a reason to send you, and you may be denied. You may be denied. Your primary may say to you, well, there's no medical indication for me to send you to a specialist. So the filters that your primary care has to work through and the consultations may not result in a specialist visit. There may be some feedback from the specialist on what to do about the problem. But that's cheaper than actually sending you to the specialist. So there are a lot of filters that you have to go through in order to see specialties.
I think that's an important point because I think a lot of people aren't aware of that, and they go to Advantage because it's less expensive. And they make that decision just based on cost. But opposed to that, you really have to look at the whole picture, especially for older patients that are more susceptible to becoming ill. You know, you may want that specialist and you may not be able to get it.
Exactly right. Now, the end result of this is it leads to delays in care.
Right.
You end up waiting sometimes months for improvement while this dialogue goes on between the specialist and your primary.
Right.
Now, in contrast, we have traditional Medicare where you can get into the see the specialist and get set on the path that specialist sets for you for treatment. And that's really good. Now, of course, you do have a better choice of hospitals. You can go to Cedars, you can go to a hospital that actually has a sterling reputation, maybe for that type of surgery or that type of cancer treatment. Now, managed care is another, or Medicare Advantage, pardon me. It's a managed care. They're looking at the health dollars that they have for you and they're divvying them out with great care. So, you may not be able to go to the hospital you want to.
Right.
And likely you're not going to be able to. You probably will be sent to a community hospital that has a decent rating, but may not be specialized in the surgery or the care that you need, if that's where you're going to get it. Now, there are cases where there's a special type of cancer disease that's out of the scope of the organization that you became a part of. And that requires a prior authorization that has to go to the managed care organization, we'll call it your health care plan, to be approved. Sometimes it is, sometimes it's not.
Okay.
In any case, your primary care physician, be it a geriatrician or an internist, is really your advocate in both systems. Now, information sharing about your conditions is really very good in most Medicare Advantage plans because they share an electronic record. So what the doctor is typing in, say from, nephrology or the cardiologist, that's readable or obtainable by your primary. And so that's a huge advantage. Now, traditional Medicare doesn't.
But the electronic records now is pretty much standard. So even if you went to, and we're using Cedars because we are familiar with the Los Angeles area, but whether Cedars or USC or UCLA, they both use Epic as far as their electronic records. So I would imagine that information is shared between both organizations.
Well, it's not as easy. Now, I'm a primary and I have access to all the specialty notes. So I read those notes before I see my patient so that I can provide a complete summary of care as it is in that given moment when I see my patient. Now, I'll compare that to some of my Medicare patients that have traditional. They may go to as many as 5 specialists, and they could be critical specialists like a neurologist, a cardiologist, a nephrologist. And I have to spend a lot of time getting that information. I cannot just make a request and get it. I can't just open an electronic chart and get that.
Okay.
So it's very different. I actually have to have the patient sign a consent so we can get the information. And once it's done, then I can request information indirectly through the patient or officially through our medical record system. But I don't have it for that day. I don't have it for that month. And the delays in information transfer actually impact the care decisions that I make for my patients.
Right.
That's the big disadvantage. And this is where your role as a patient is very important. If you choose traditional Medicare, always make sure you get copies of that visit with your specialist and bring them to your primary, especially the labs and diagnostics, because that way those tests will not be repeated, misspending your healthcare dollars.
That's really great. That's a great tip because I don't think most people would think to ask
You're absolutely
for those.
right.
Right.
They do not.
Okay.
Well, it just helps for preparation for the visit.
Right. And you know, the other thing that I think is important, and I'm sure that you'll agree with me, is people in this day and age, whether you are familiar with the healthcare system or not and functioned as we have in our lifetime, you have to be an active participant in your care.
You have to be your own advocate.
That's right.
That's right.
So knowing all of this information, knowing to go in, and if you're going in on regular Medicare to a specialist, to ask for notes and ask for your labs at the end is really important.
Right, because it would make my job a lot easier.
Right.
Now, of course, I did want to talk about a primary care physician. I'm a nurse practitioner, so I'm primary care, and I manage the way a physician does because I have my own panel of patients. Sometimes you'll have a physician's assistant because nurse practitioners can become full scope providers. But the point is, whoever your
What is a full scope provider?
That would be someone who's a mid-level like myself, a nurse practitioner, or not physician's assistants, but nurse practitioners with more experience and more hours. We can apply for a license that allows us to function independently with no supervision.
So for the people that don't know, a lot of nurse practitioners are supervised by a physician, and they're okay. The physician approves like their decisions, like.
Or they review them. They'll review a certain percentage.
Okay.
Now,
And so if in the case that you're talking about with someone with your experience, you don't have to do that.
ultimately, no. I can put my shield out and we can just have a chat. But I do want to emphasize the importance of having one central person. It could be an internist, it could be a geriatrician, it might be your cardiologist, but that's not likely. I think for adults, an internal medicine doctor or provider is a very important choice to make because you can bring your data, your information to someone who understands adult medicine. And this person can help shoot you to the right person, make comments about where we want to go as our next step together.
Right. And in a way, you know, there's been all of this talk I know about, especially with geriatric patients, about having a team of people that are always communicating. And this way, you're providing that.
Exactly. Well, actually, you're talking about an important trend in medicine, which is providing bundled services out of one practice. Now, a lot of the managed care organizations attempt to do it, but they don't do it very successfully. Private sector, though, where you have independent practices, they are doing that very successfully. Now, remember, they might call themselves functional medicine practices or holistic practices, but again, look at what they're actually doing. The concept, though, is exciting, very exciting, where you can get your physical therapy, you can get your occupational therapy, your behavioral health support, even a life coach.
Right. That's awesome.
Exactly. But the thing is, these are all obtainable if you look in the right places. Maybe not bundled, but you can get these services. And
But again, we get back to be an active participant in your healthcare.
yes, exactly.
And make yourself, the more knowledge that you have about the arena that you're working in, the more powerful you can be.
Well, actually, you made a good point at a conversation we had, and that is internet literacy. You absolutely have to be able to get information on the computer and be friendly and be able to learn a few new tricks because you need the new tricks to take care of yourself.
Right. Okay, now we're going to talk about the big surprise segment of our healthcare that a lot of people don't understand.
Isn't that the case?
And that's Part D.
Part D. All right. In Part D, I'm going to introduce you to your pharmacy benefit manager, your PBM. So let's just imagine what the healthcare map looks like and where this PBM fits in. So over here on my right hand, we have your healthcare organization. So this is where your dollars for healthcare enter. The person that is your primary care, your internist, your, you might say, coordinating healthcare professional. is here. And this person is your advocate. So what happens to this money? I think you're going to be surprised. A lot of it goes to the pharmacy benefit manager. Some of the dollars go to the pharmacy for the cost of dispensing. Some of these healthcare doctors, or I should say doctors, sorry,
with
that was
dollars.
really good. Well, maybe they're healthcare doctors. In any event, they go directly to the drug company. But the funds are directed mostly by the pharmacy benefit manager. So what do? They have a certain number of dollars that they have to manage to provide you with the medications that are covered by your benefits. So we would call that the formulary. So they decide which drugs are generic that are going to be covered, which drugs are a little bit higher cost, higher tier, and then those that won't be covered at all or that have a very big copay. Now, as you know, by looking at your plan, generic drugs, or what we call tier 1 drugs, don't have an extra copay, or it's minimal, maybe $5 per prescription. But when you jump to tier 2, then the price really starts to go up.
Right.
At tier 3, it could be impossible for you to even afford. So you're probably wondering, well, how does my PBM or pharmacy benefit manager make these decisions? So that's what I'd like to explain to you. First of all, any drug that's generic is going to be inexpensive. And to protect the profits of the drug companies, companies have to wait approximately 7 years or so before drugs go generic, or they come off the patent status. So brand name drugs, the ones that you see advertised, because you don't see acetaminophen advertised because that's a generic. And you don't see loratadine advertised because that's a generic.
Right.
So once something comes off brand name status, the price goes way down. And those will be drugs on tier 1. Now, the pharmaceutical industry is very good at just changing one molecular structure or adding on another ion to issue a brand new drug that works maybe just as well as one of your blood pressure medications, like losartan or lisinopril. But that little twist in the molecular structure, the chemical structure, allows this firm to release it as a brand new drug and protect it from being forced into generic status for 7 years at least.
Right.
And in some cases, if it's a more complex mix, it might be as long as 11 years before.
And that's a benefit to the pharmaceutical companies,
Oh, of course it
because
is.
if they have a drug that's just slightly tweaked, it's basically extending the same patient population to this new drug,
Well,
if they can.
You started on a very important thought, which is it maintains the drug price on the market for a longer time. So the lookalikes, that's what we call them, the lookalikes can be twisted a little bit, and then they go on the market as a new medication. Now, the Pharmacy Benefit Management Group is looking for things like that to try to offer a medication list that's acceptable, that's obtainable or reachable, and also treats the major diseases and gives the primary over here or your specialist in the managed care organization, your health plan, some space in which they can move and get you the right type of medication for what you need.
Right. But in this scenario, I think one thing that people need to be aware of, and a lot of times they think physicians get slack, or providers like yourself, get pressure from their patients. You and the physicians are their greatest advocate, because you are the ones that are interfacing. And when they get denied, when the insurance company denies them, that's because of the PBM, right? So they get denied, you're the one that has to apply and make an appeal.
I'm so glad you mentioned this. So we enter this process called prior authorization.
Right.
So for one medication, for me, it's a 3-page form. Then I have to go into the complete history of all the other drugs I've tried to use as a justification. why I'm asking for this drug. Now, I imagine you can appreciate how much time this is for one medication.
Right. And in your day, I don't know how many patients you see in a day, but let's say you see 20. And I'm making this up, but you see 20 patients. And how much time that takes you in a full 8-hour day or longer to see those patients. And now you've got a 3-page document. How long does that take you over and above?
Yes, and that actually does impact whether or not a physician primary is willing to do this. The reason has to be very, very important to dedicate this type of time. Now, the advent of the electronic medical record wasn't a time saver for any of us because it was accompanied by many quality standards, which we needed, and many quality indicators. But it adds on an average of 2 hours a day, at least 8 hours in a week, to the time you spend caring for patients and doing your documentation.
Yeah.
So when you're given a 20-minute visit and your provider starts to get a little bit time concerned or starts to move and, this is the end of our visit, what have you, we need patients coming in to generate funds and pay the healthcare plan personnel and make a profit. Because most companies are for-profit. In the past, there were many not-for-profit agencies and healthcare plans, but that's not the landscape anymore.
And I think that's really an important part. And this is good information for people outside because they may not realize, when maybe a provider is maybe a little short with them, is they've got other patients waiting and they've still got hours of work in front of them.
Exactly right.
Right. So, I think that the public sometimes blames the providers, and that's really not a fair scenario.
Well, thank you for making that observation.
Right.
Because we work way more than the office hours, way more. And it accounts for a lot of overtime.
Right.
And if you're in private practice, you don't pay yourself overtime.
Right.
You're just there at the office.
And I think the lucky thing is, I suppose it depends on your specialty, but for years I called on psychiatry. Many doctors don't have the benefit of having a staff to stay on the phone for 45 minutes waiting for somebody in the insurance company to pick up the phone or...
Exactly right.
Yeah, so I have a lot of empathy and for my heart goes out to the staff because I've seen what goes on in the office. So anything else we should know about?
Actually, I think you should. We should be aware of who owes what and who owns what. Now, you probably have noticed that some of your favorite pharmacies like CVS and Rite Aid are closing down. And suddenly we're seeing all these empty buildings. Well, inside of the healthcare industry, there's been a lot of consolidation with one buying another piece of the healthcare pie. So let's remember, your health plan is your medical group. So a lot of these medical groups actually own their own pharmacy benefit management companies. Now, they should be independent, but they're owned by CVS. Let's take CVS as an example. But then they own their own pharmacies. Now, if you think about greater consolidation, one group buying out another, buying another pharmacy benefit management company, there's greater and greater consolidation.
And they're also buying the physician groups.
Absolutely, which is part of the plans.
Right.
And with this going on, it means prices go up. There's no competition. And competition is known to bring down prices.
Okay, so I have a question. So what about for Medicare patients that are really low income and maybe can't afford some of these different segments of care? What happens to those patients?
A lot of us will cover that part of the cost of our health care by having a Medigap plan that we pay for. But for those people that have very, very low income,
So the Medigap plan would be like a supplemental, what a
yes,
lot of
exactly.
people call supplemental.
So for people that aren't able to afford a Medigap plan, we have Medicaid in the rest of the United States, and we have Medi-Cal for people that are in California. So you have to go to the welfare office, the county welfare office, in order to qualify for that. Some people will get their information but don't make the application. They get information from Medicare, but you actually have to apply for Medicaid or Medi-Cal. Now, the Medi coverage, Medicare plus Medi-Cal, has actually been really good. One big thing that people start to notice when they go on Plan D is that pharmacy benefits don't cover vitamins and a lot of things that were covered when you just had, say, Medicaid or Medi-Cal. Now, for instance, I can prescribe many needed vitamins. I can prescribe acetaminophen, painkillers that are over the counter, and it was covered by Medi-Cal. But when you make the transition to Medicare, that's your primary insurance, and it doesn't cover over-the-counter medications. So this comes as a big shock to people that have been relying on their Medicaid, Medi-Cal benefits, where these over-the-counter drugs were covered. So with that said, there is much worry and concern about what's happening to Medicaid and Medi-Cal benefits. The Affordable Care Act allowed a lot of people to get very good coverage through Medicaid or Medi-Cal because it took people that were at a more, as an elevated income level. So we start with poverty level. That automatically will qualify you to have Medicaid or Medi-Cal. So for an individual, it's about $15,800. Now, we know in California, nobody can live on that. But with the Affordable Care Act, poverty plus 138% was the range in which you could reside, if you will, and still get Medicaid without a copay. Now, the supports for that looks like they're going to go away because the government is trying to save money and economize. So with that said, that means there will be copays for people that have Medi-Cal or Medicaid. How much, I can't say, but if Medicaid or Medi-Cal eligibility is based on poverty level, the federal poverty level of $15,800 or so for an individual, you can see that many of us are going to fit into the income group that can be eligible for Medicaid, Medi-Cal, but will have to pay a copay. And at some point, you just don't become eligible for it because of your income.
Right.
And Social Security and your retirement income could push you right off the eligibility scale.
So it's sad, right? I don't know how much, a poverty level, $15,800 a year. I mean, it's hard to believe that anybody could exist on that.
Well, that was in 2025. So the poverty level goes up very, very slowly. It's something that should be indexed to the cost of living, but that's not the way it's arranged.
Right.
Now, there are other ways where you can lose your Part D or your secondary insurance. So for someone who has very low income, they have to fill papers out periodically to get their Medicaid benefits. If you miss those deadlines in many states, you're just thrown off the plan. So you could actually have your Medicare functioning, but no access to medication. So it's very important to stay on top of the paperwork. And if you don't understand how to fill out the paperwork, get some help.
Right. And again, this is another, area that we can stress to people. I know that a lot of people that are older don't really, maybe for whatever reason, don't want to learn about computers, or maybe they have grandchildren and that use them and they think it's a toy, but it's a very essential productivity tool. and it gives you the ability to access accounts like Social Security. Now you can only access your account online. All of these things can make your life better. You can find out about what deadlines are, all of those things. So I would encourage anyone listening to this to please try to be a little more proactive as far as learning basics on basic computer skills.
Well, your point is so well taken, because it's becoming harder and harder to access anything by phone, because remember, a lot of Social Security offices are understaffed now, also part of the cost savings actions taken by the current administration. So the ability to walk in and get answers, that's something of the past.
Right.
So fewer people demand the phones, and then also making appointments, that becomes cumbersome. Going into the office may be your only way, if you don't use the internet, to actually getting an appointment to get your problems looked at and resolved. And that worries me.
Right.
Some people are not able to get into the office.
And there are many doctors and many specialty groups that have, like My Chart, which electronic charting, where actually patients can go in and view their summary notes from their visit. They can send a message to their doctor or to their nurse practitioner. So it really is a way to stay connected. So I would say, please, if you hear this, try to be open to being a little more proactive with computer skills. And the other thing, and I have no interest in this, I'm not sponsored by Apple at all, but Apple has free classes every single day.
Very good support.
Right, and very good support. And their customer service is really great.
Now, most of my patients have cell phones and they use Facebook. But when I ask them to text me on our portal, well, I don't know how. So I ask myself, here you are on social media, but you couldn't make that extra step. Now, at my institution, we have an advocate who you could say a navigator, who helps people get sufficiently, you might say, able to at least text their providers. And it doesn't always work,
right? Because
people are afraid of technology.
I agree with you. And, one of the transitions for me, I was still in corporate America, and we went from voicemail to texting.
Yes.
Right? It was that much, it was a transition that happened overnight. So absolutely, I was really pretty accustomed to doing that, even after I retired. But I think there's a lot of people that aren't, or they don't check their phone. That's another thing. You can text them and then 2 weeks later you get a response. So I would just say, again, I don't want to belabor this, but it will help you so much.
And setting up your mailbox, please.
Yeah.
Audience, set your mailbox up so at least you
can get messages. And it's a phone. If you have an Apple or you have any of those, it's a phone call. They'll walk you through it.
Exactly.
They're really very helpful.
So when you go shopping for your electronics, make sure you make choices with companies that give you really good customer support.
Right.
No, we have no financial interest in Apple.
I don't.
But we like it.
I like it very much. And for the one thing I would say is that somebody answers the phone and they actually know their product.
Yes, exactly. Okay. I did want to talk about the Inflation Reduction Act.
Oh, good.
Some of the changes that it implemented that were very beneficial to patients. Now, in 2022, the Inflation Reduction Act actually put into law the ability of the government to negotiate with these big drug companies to bring prices down. When Medicare Advantage was first conceived during the President Bush's administration, the government was pushed out of the negotiating purpose, out of the market. So they couldn't bring the bear of like Walmart buying power, or even greater than Walmart.
Or Amazon.
And start to negotiate with drug companies to force them to bring prices down. Canadians, Australians, the people living in Northern Europe, they do not, and the Japanese, they do not pay what we do for pharmaceuticals. So that act in 2022 was a big benefit that should introduce even more cost savings. Now, I don't know if any of you have been covering the price of insulin. Insulin had gotten so high it was hundreds of dollars a month for some of my patients. And this act has forced the companies to bring down their insulin prices. So getting the government in to negotiate with the insurance companies means that you have massive government leverage on bringing prices down for consumers. So that was actually a really good bill for you and me as retirees, although I still am working. Now, what happens? Prices start to come down. And how does this work? So there's been a couple of changes in the bill that I think you're going to like. All right, so 10 drugs a year that are really expensive are subject to these provisions. So what happens is that there are two categories of drugs that are subject to these provisions. Number one would be drugs that are really expensive, say for hepatitis C, orphan drugs, that sort of thing. The other would be categories of drugs that are used to treat massive numbers of patients. For instance, hypertensive, huge group of Medicare patients. So drugs that would treat hypertension, heart failure, diabetes, not just because they're expensive, but they're needed for large groups of people, are also in the group of drugs to be negotiated. So as long as that clause of the Inflation Reduction Act is still left in place and not tampered with, we do have a mechanism by which we can review drugs and tap down prices. Now on some drugs, there are now ceiling prices as a result of that act. So that was an important benefit to consumers. So that's actually what it does for you.
Great, right. Now, is that going to continue with
that's
the
a
new
good question.
the new administration?
It is very possible that might be repealed entirely in terms of the healthcare provisions. This one is, I would say, tuned to what's happening in Washington. I would put pressure on your elected officials, and your party's not important. This is about your self-interest. This is about you being able to have good health care and controlling the profits that our pharmaceutical companies are making. We want to make healthcare as accessible as possible, and that's a challenge for all of us. Doesn't mean that if you're Texas or Washington, it's a problem that we all have. So pressure on your local representatives, your senators, your people in Washington.
Right.
Let them know that you're concerned about this. And also you should be concerned about those subsidies that were built into the Affordable Care Act, because I am worried that people that are a little bit above poverty who are getting the Medicaid plan or Medi-Cal are probably going to have to pay copays. And where does that come from?
Exactly.
I'm very, very concerned. Now, some of the changes in 2026, when the Medicare Act was, I should say, the medical, the Advantage plans for Medicare were first instituted under President Bush, there was a donut hole in benefits. Now that was moved around to be a copay that you had to come up with in January. Every January, $2,000 out of your pocket before you could get any of your medications. Let's say you don't have it. Well, there was a change in 2026 allowing you to take that copay and spread it out over 12 months.
That's great.
Well, as I've talked about Medicare and its different parts, you've probably become very aware of if you don't do things in time, you're going to pay a surcharge. So that would be the first step when I think about getting my full benefits out of Medicare, whatever plan I decide to choose. The other thing is that when you first enroll, there's some mistakes that are made that can have lasting consequences. So I'd like to go over those. First of all, you've got to make sure that your provider, the one that you've seen for the last 20 years or 30, is listed in the Medicare Advantage plan. And I do want to point out that physicians, healthcare providers can move around. They may not be covered by this Advantage plan in the future, but I mean, when you're starting to sign up for a plan, you should have that as your number one consideration. Is my physician or my healthcare provider in the network that's accepted by my Advantage plan?
And that's only if you signed up for Advantage, right?
Exactly. You wouldn't have this problem with traditional Medicare because...
If you do a supplemental, you don't have that.
Exactly. But even with traditional Medicare, you don't have them. The Advantage plan is going to charge you more if you see somebody out of network.
Okay.
So some of my patients will see the original provider that they had, say their cardiologist, and then the family comes up with the extra money to pay for the outside fees.
Mm-hmm.
But not everyone is endowed with that much money. And because of our tight budgets, we want to make prudent choices.
Mm-hmm.
So make sure that your physician, your coordinating physician or healthcare provider is listed on the plan. Remember, anyone that you see outside the plan, not on their network, means that you're going to pay a whole lot more.
Okay.
A whole lot more. So that would be the number one mistake that people make. Number two would be making sure your medications are covered. Now, each plan covers their tier 1, tier 2, tier 3 drugs. That's a list that's publishable. It's on the company website. Make sure you look, make sure your medications are covered.
Right.
Now, could that change? Of course it can change. And I gave you some of the reasons that it is change. And then thirdly, not being realistic about the care that you need at the age and condition you're at. You may have to change plans. Just because you're getting older, you're not as strong as you were, you maybe can't drive anymore. Now that would be a good example. If you can't drive and you're having trouble getting to your doctor's office, an Advantage plan that covers some home health visits or having the provider make periodic visits to your home, that could be advantageous. So we have to be realistic about how we are physically and mentally and our ability to access care when we choose our plans.
Right. And I think, I think this is difficult for all of us, but I think that you do have to be realistic that the risk for you as you get older to need more services is just, it increases with age. It just does. And just accept that, and again, take in the information that you need so that you're more in control of what happens in your care.
Absolutely. And if you are becoming more isolated from your healthcare physicians, providers, physical therapy, there are ways that physical therapy can be prevented, can be conducted at home. A home health agency can come to you. Now, sometimes the quality is really very good. I've done home care as a nurse practitioner. And what I've observed has been excellent to less than mediocre.
Right.
Just so long as the provider knows how to do the documentation, they're able to collect for the visit. So the quality of care may range quite a bit.
And I think this is true. We've heard in Middle America now they're getting rid of Zoom calls and, telehealth. So for reimbursement for that. So for those patients, trying to find out who can come to their home, because if they're in a rural community and they have to go 50 miles to see a doctor, they can't do it. Right.
Well, actually, you just started on another interesting subject. If there are restrictions on public insurance programs like Medicare or Medi-Cal, Medicaid, certain hospitals are already going under, like rural hospitals.
Right.
And that means that how is a person in a rural community supposed to get health care? Now, in those areas, telehealth will continue to be an important way of getting your health care, especially if you do a video visit. It's not the same as seeing someone in person, but at least it makes medical care accessible.
Right. Right.
So these are all things that are in flux now.
Right, I agree.
And we have to keep our eye on the trends.
And make sure as a patient that you know what's happening, because you
yes.
don't want to do a telehealth visit or, you know, a Zoom call and then get an exorbitant bill and not know what it's from.
Oh, absolutely.
Right, because if they eradicate any kind of reimbursement to the physician side, you know, then it's like, well, you're going to have to pay for it then.
Yep, that's right. That's why I predict that there's going to be increased cost sharing in the future, irregardless of your income level.
So, all right. So now, if you could, can you give me 3 best takeaways from your presentation today?
Not a problem. I remember when I hit 65, all these crazy telemarketers started to call me about Medicare Advantage and about the benefit of Part D. And I just thought, this is crazy. I'm not retiring. But then I began to put myself in the shoes of my patients. And they're absolutely confused, bothered, and angry about all the calls. So don't believe the telemarketers in terms of what they tell you, the provisions or the benefits are going to be. You're best off doing your own research. So there are 2 ways to do this. There are many good not-for-profit organizations. It doesn't have a .com at it, it has a .org, such as AARP, that have very, very good side-by-side comparisons for your Medigap, as well as certain Advantage plans. So do your research. I think we've said that a few times. Second thing is, do understand the difference between traditional Medicare and Medicare Advantage. I hope that the little bit I've shared with you will help you make a decision that's good for you. And then thirdly, choose the program that best meets your needs. We talked about home care, we talked about home care visits, we talked about some of the barriers getting to the healthcare clinic, but be realistic and inform yourself. Always inform yourself.
Well, you know, again, I can't imagine anybody listening to this isn't going to really be excited, because it makes it's so convoluted, this whole topic. And as long as I've been in the industry many times, I've struggled with it myself, professionally as well as personally. So I so appreciate you being here today.
Well, Shelley, I think this platform that you have, bringing really important subjects to your audience, is a very important gesture and action you're taking.
Wow, thank you. Anyway, Margaret, I hope that I get you on the program again for another topic, but I thank you so much for being here today.
Well, thank you for having this station and inviting me.
Most happy to have you here.